Welcome. This is our Week 8 group project for our High Quality Care and Patient Safety class. As an introduction to our presentation on the various leadership roles in patient safety, we would like to begin by pointing out that as the pressure to improve patient safety has grown, healthcare organizations have had difficulties creating effective structures to support and manage patient safety. As we can see, patient safety dates back to Hippocrates, and the IOM to Era's Human Report created national public pressure to address patient safety issues with system-wide changes. The qualifications and training of the patient safety officer. Patient safety is an emerging healthcare discipline, and patient safety officers should come from diverse backgrounds with unique personal traits. Ideally, they will have a clinical background and training in human factors, IT and risk management, and culture change. They must be a team coach who cultivates and maintains positive relationships within the organization, as well as with outside regulators and accreditors. The patient safety officer must partner with shareholders at the organization to provide strategy and oversight of all proactive and reactive initiatives related to patient safety. Ongoing education and training is important. The American Hospital Association, in collaboration with the National Patient Safety Foundation and the Institute for Healthcare Improvement, are two of many venues available to provide education on patient safety theories and models. Every state and national healthcare professional association offers lectures and/or workshops on patient safety topics. Patient safety officers must also stay abreast of journal articles, online materials, governmental and professional association resources, and textbooks. Other formal patient safety fellowships, core curricula, and certification programs have also emerged. The role of the Patient Safety Committee. This is an interdisciplinary committee charged with the coordination and implementation of programs for ensuring patient safety within medical institutions. This committee evaluates trends from quality reports, adverse event analysis, and other sources and recommends appropriate actions to oversee proactive risk reduction and improve patient safety throughout their medical institution. The committee will survey clinical and medical staff to identify areas for improvement in the understanding of patient safety principles and actions. Patient safety committees are generally made up of a diverse group of clinicians and hospital administrators. Some institutions also include lay members, such as counselors, pastors, or other community members. Patient safety committees will need to address many complex challenges. When it comes to the function of the committee and how it interacts with the organization as a whole, it is crucial that the committee's focus remains on improving safety rather than reducing the organization's legal exposure. Patient safety committees have direct responsibility for setting up protocols and procedures that will directly affect care on the front line of the organization. They must initiate specific steps to reduce medical errors while recording and tracking errors and also monitoring how their patient safety protocols are shared among healthcare professionals within their systems. They must also interact with overlapping committees, such as risk management and quality improvement, and agree on a clear mandate to focus on patient safety. Incentives and/or disincentives that have helped reduce medical errors must also be researched and understood. Finally, the committee needs to think outside the box by setting goals and being forward-thinking rather than spending its time in reactive and compliance mode. Engaging physicians in patient safety. The incongruity between the Hippocratic principle of doing no harm and the lack of physician engagement in patient safety is striking. In fact, a survey of the American College of Physician Executives reported that only 34% of hospital physicians were very supportive of quality and patient safety improvement projects. Physician involvement and buy-in is critical to patient safety success. Time constraints are another sensitive issue for physicians that contribute to the competition between hospitals and independent physicians. These physicians are trying to balance their time, but receive no extra compensation for patient safety activities when employed by hospitals, which creates obstacles. Insufficient IT support and inadequate medical school training have hindered physicians' abilities to fully participate in quality improvement. Coupled with the clinical peer review process and the concurrent support of a patient safety organization relationship, hospitals can engage physicians and accelerate the learning required to improve patient safety. The Patient Safety Act offers protection to physicians who are reluctant to report adverse events. Providing physicians with new, evidence-based recommendations and turning them into champions and advocates for patient safety will help to spread buy-in to their colleagues. Board engagement and patient safety. Traditionally, hospital boards have delegated quality and safety to the medical staff in order to focus on financial goals. Another reason is that board members are often lay people who do not understand the clinical elements of quality and safety. In fact, a 2006 study by the Joint Commission found that board chairs and CEOs had little familiarity with the Institute of Medicine's landmark safety and quality report, To Err is Human. Transformational leadership in healthcare requires hospital boards to be engaged in quality and safety. Board leadership is a critical ingredient to achieving better, safer care. Leadership is critical. Only senior leaders can direct their healthcare organizations to foster the culture and commitment required to create a successful patient safety program. To accomplish this, it is important to educate board members on quality and safety. This may include attendance at safety conferences and also adding quality experts to the board. Encourage a culture of safety that is non-punitive, open, and self-evaluative. Create a patient-centered focus. Share patient stories at board meetings and involve patients in improvement strategies. Communicate a clear vision and goals. Pursue perfection, not improvement, by asking, what is the best performance that a given process or system can achieve? Build quality measures into the organization's strategic milestones and in the CEO and board's performance evaluations. And create financial incentives to recognize and reward excellence in quality care and patient safety. In conclusion, patient safety is an emerging discipline requiring support and endorsement at all levels of an organization. But leadership and a foundational structure are critical. Key elements include selecting a patient safety officer with an interest in safety and leadership skills in team development. Focusing on diverse and forward-thinking individuals on the Patient Safety Committee. Prioritizing patient safety by engaging physicians and establishing a clinical peer review process. Educating the board on the importance of patient safety. We'd like to end our presentation with this quote from the IHI's Leadership Guide to Patient Safety. When leaders begin to change their response to mistakes and failure, asking what happened instead of who made the error, the culture within their healthcare institutions will begin to change.